My name's Pete Moore, and I first experienced back pain when I was around 16, 17 years old, and I've had osteoarthritis in my hands and feet for the past 11 years. When I turned 40, the pain increased and I spent a lot of time away from work and just resting. 18 years ago, in 1993, when I was at work, I prolapsed 3 discs in my back. The resulting ongoing pain was incredibly debilitating and affected all areas of my life, including my work, money and relationships. I then became isolated and felt very depressed. I saw my GP first and was given a muscle relaxant, anti-inflammatory and strong painkillers. I also saw a couple of osteopaths who told me I have a prolapsed disc and they would eventually heal. But after 8 weeks I was referred to see a physiotherapist, who after 5 sessions then referred me back to the GP as I was making no progress. I was then referred for an MRI scan and then to an orthopaedic surgeon. He told me my spine was like a crumbling biscuit, which reinforced the message to me to avoid movement just in case I caused more damage. All in all, I became a doctor's shopper and saw about 20 different types of therapists. Pain was beginning to control my life. I started to use it as a measurement or a guide. When the pain started or increased, I stopped and rested. And when it decreased, I became more active again. 15 years ago, I started a back pain support group and began to learn from others how they managed their back pain. One of our early speakers was a clinical psychologist who was part of a pain management program, and she actually spoke to the group about graded activity and pacing to avoid doing too much on one day and less on others. So then I applied to go on the pain management program. I initially applied for the program as I thought it was something I could do for myself and it would help me put me back in charge. I hoped it would build my confidence back and help me get my life back. It was a multidisciplinary inpatient program, a 10-day course in a hospital where me and a group of patients suffering from pain were educated by various specialists. The specialists on the program included an anaesthetist, a physiotherapist, clinical psychologist, occupational therapist and a pain nurse. We were split into groups and were spoken to about different aspects of pain. For example, the clinical psychologist spoke to us about pacing and techniques that help us to no longer use our pain as a measurement. And the pain nurse spoke to us all about medication. They helped us to work out what we could or couldn't do and started us on gentle graded stretches and exercises. We were given the knowledge and skills to help us learn from our mistakes and to manage the pain ourselves. The most important thing for a patient to communicate is the type of pain they're in and how it feels. For example, is it a burning pain or is it a numbing sensation? It can be useful to visualise the pain and tell the doctor what colour it is. The patient must also let the GP know about the frequency and the intensity of their pain, and using perhaps a pain diary could be useful for this. The simplest way to do this is using a scale where the pain is rated from 1 to 10, and a change pain scale developed by Grunenthal could be a useful tool for this. It's also important for the patient to tell the GP about the impact the pain is having on their lives. For example, pain may have stopped them from playing with their kids or visiting friends or going to work, as returning to work is also part of rehabilitation. The GP needs to consider the biopsychosocial aspects of the patient's pain. So if these things are important to the patient, then it must be considered by the GP. Firstly, the GP should speak to the patient in a language and manner that the patient will understand, not using or avoiding technical jargon. They should assess the knowledge of the patient, finding out what they know, how they learn and adapt their approach so they're communicating to them at their own level. It's also important for the GP to ask the patient what they think the problem is. thereby putting some of the onus and responsibility onto them. That way the GP can set out a clear action plan and contracting consultation with the patient, which is developed with their buy-in. This gives them some kind of ownership over their management strategies, meaning that they are more likely to follow the plan. The action plan should set out what the patient should do before the next appointment, as well as what the doctor should do. So for example, the GP might arrange an x-ray while the patient might look around for a swimming pool to exercise in, or perhaps find a yoga or tai chi or other simple exercise class to attend. On the next appointment, the action plan can be reviewed to see what each has been doing, and then the next steps can be developed together. One example is to give the patient some resources such as the pain toolkit and tell them to go away and look at it and circle 3 things they'd like to work on together for the next time they meet. The patient is then locked into something that they are going to work together on, which promotes teamwork. It can also be important for the GP to reassure patients that pain is not uncommon. Every other patient they see has some kind of pain issue, as the patient could be anxious. This should help them put them at ease and may give them the confidence to more clearly discuss symptoms and management strategies. If the GP is prescribing medication for the patient's pain, they need to ensure the patient is clearly told about basic information, such as when to take it, for example, in the morning or at night, and how to take it, with food, etc. It's also really important for the patient to be clearly told about associated side effects so that they know what to expect. This can help reduce patients' anxiety, can help them stay compliant. The medication dose may need to be altered because of the implications of side effects, so the GP should clearly discuss how this happens, for example, increasing the dose, as well as what side effects to expect and how they may be able to be managed. It can also be useful for the patient to receive information from the GP about how to manage their own pain. The GP should have access to such materials that they can pass on to the patient. However, they need to consider patient engagement and the type of information they're recommending. For example, can the patient read, or does he or she have poor reading ability or vision or cognitive difficulties? Would it be more useful to direct the patient to snapshots of information as opposed to long written material? Would it be more successful to direct people to more engaging information, such as videos, or put pictorial information instead of text materials? The patient needs to take an active role in any referral process, and ideally should even request referrals if they feel confident to do so. The patient should also be involved in any decision-making process, given all the options for referral and in developing an action plan with the GP. So for example, the patient may request that they are seen by a certain specialist or a team in a clinic or university setting. That may include a physio, rehabilitation specialist, psychologist, who can help them manage their own pain within that kind of setting. That way the patient has a buy-in to the decision and is more accepting of the next steps, especially if that is in a secondary care program that may be unfamiliar to them. It's also important to encourage the patient to be honest and clear when discussing the nature of their pain, so the GP can recommend the most appropriate referral in the right timescale. These measures allow patient outcomes to be improved, and secondary care programs become more useful and can show that they can reduce people's disability, can help facilitate them getting back to work. This provides evidence that they are cost effective and can help them gain funding. Patients want to know how long the referral process will take, as in some cases the longer it takes, the worse the person's pain can become. Therefore, as soon as the pain has been diagnosed with the biopsychosocial approach, the patient needs to get into the system as soon as possible, and If there is a long waiting list, they could be referred to a self-management workshop. If a patient is being sent to a hospital to be treated, they can become anxious because they might associate hospitals with a serious health problem. Therefore, the GP should make them aware of the referral location as soon as possible and try to reassure them. The GP must also manage the expectations of the patient regarding treatment and tell them what to expect, that there may not be one solution but a multidisciplinary approach that tackles the different aspects of the pain and how it can help them make it more manageable. There are so many different types of pain: rheumatology, neuropathic, musculoskeletal, diabetes pain, headache pain, pelvic pain, etc. So we really need the multidisciplinary approach to treatment with, for example, a psychologist, a pain nurse who specialises in pain medication. A physio can teach pacing and exercises and stretches, and an occupational therapist who can show how to do everyday duties. But most importantly, the patient needs to sit at the top of this structure and have an active role in the decision-making process as well as the management process, using techniques to manage their own pain in coordination with the multidisciplinary team. The patient must be fully on board with the treatment approach and not just have a passive role. In my own experience, I've seen that this means they are far more likely to engage in a management strategy and actually exercise, use techniques, or take any medication, all of which can help reduce their pain. Firstly, patients must have the confidence to be honest and open and ensure that they have told the GP of all their medical problems. So, for example, if they have constipation, the GP can then inform them if the medication could actually make things worse. That way they know what to expect and are more likely to stay more compliant with the medication. Doctors must be clear about medication, for example, the active ingredients, as well as the benefits of the medication and the effects it's going to have. So, for example, if painkillers might not kill the pain completely, but it can block the signal, and the pill may not completely solve the problem. GPs must be honest. The pill may take the edge off the pain, but it's not the complete answer. It's just a short term. The GP must also allow the patient to ask questions, as they may not understand the treatment approach or medication or administration, or they may be anxious about potential side effects. It can also be useful for the GP to discuss how the patient can get into the routine for medication taking, as well as suggestions for strategies to remind them when to actually take the medication. So, for example, they may want to use post-it notes, telephone reminders, or just leaving their medication in the kitchen if it needs to be taken with food, or using a dosset box. The GP should be extra vigilant with older people with pain, who may be more prone to forgetting when to take it. They may need to discuss with the carer or family member strategies for helping, such as preparing a dosset box for the week ahead, so the patient knows clearly if they have or haven't taken their medication for that day. For people who are more confident and familiar with using the internet, websites where you can enter details of health problems can be useful, as these can be shared with your nurse or doctor so that they can monitor you effectively. The GP should clearly set goals with the patient at the outset. For example, playing with the kids, getting back to work, or just being able to walk. Asking them what their goal is and then developing an action plan with them on how to reach that goal, ensuring that there is a stepping stone approach so that the patient has small tasks to do at a time. This makes things more manageable and the patient can see some quick wins early on. Too much in one go can actually lead to failure and make the patient feel like there's no hope. A useful resource that has been developed to help the patient get started in management of their chronic pain is the Pain Toolkit. It can help patients make sense of these small steps and helps them break down barriers. It sets out advice and coping strategies in a clear, uncomplicated format. So to summarise, progress and good outcomes can only be made if the healthcare professionals and the patient work together as a team and agree treatment options and self-management strategies.